So we stopped here, and so we'll just get started. So of our exemplars, who do you think this is? Like represents?
Anxiety.
I can't know if y'all are saying at all.
ADHD.
ADHD? Yeah, ADHD. So what are some signs and symptoms of ADHD? Do y'all know anybody with ADHD in general? So how do they normally act?
They can have
You said obsessive?
impulsive,
Oh, impulsive.
hyperactive.
Yeah, definitely. All of those things. So basically, it's just like a neuro development disorder that affects like children and adults. Most of the time it's called in childhood. And like you said, inattention, hyperactive, impulsive. There's an unknown.
It's
You found it? Oh. They can't focus on learning new things, completing tasks, and most of the time, you all know like some of the medications that people get put on for Adderall, Vyvanse, Ritalin, all of that. So with that, we also do like psychotherapy, teach them how to modify those behaviors, as well as individualize it to the patient in particular. We want to create a safe environment, minimize the stimulation. So maybe like when they take their exams off by themselves, or make sure they're in smaller classrooms as children, like 5 or less. Our concerns with taking some of the medications, we do like drug holidays, so they don't get like used to being on that medication, then we have to keep increasing the dose. So we wanna constantly reevaluate, so like over summer break, they may be off of it, or over Christmas, they may not take the medication. Cause we wanna manage the drug tolerance, and we don't wanna stop it suddenly at all. And sometimes as an adult, they'll just take like the weekends off of the medication. Or if they go on vacation, maybe not take it.
Age. Can you give us the medications again?
Ritalin and Vyvanse. Yes.
You said, sorry, you said they take them, the weekends off of taking it?
So sometimes adults will take the weekend off
Just
just,
say that's not good, like, don't do that and do
they
it.
can take off for like the weekend for like a little drug holiday. But most of the time kids take off like during the Christmas breaks and over summer. So they don't build up a tolerance, and we have to keep increasing the dose.
So like, how often are they on this medication? Like, because like, this doesn't like go away though, right, like this disorder?
ADHD, usually no.
They like be on medication for like forever or?
Yeah, and they'll change the medications depending on how, that's why we have to keep constantly reevaluate how the drug is affecting them and if it's working for them. So they might go through 3 different drugs.
Or, I think that's why therapy is important too.
Yeah.
And if they're in school, they'll have an IEP, usually if they're in public school.
Yeah, it's very important. That's why you have to constantly reevaluate. So, these are our general anxiety disorders that we can, so overall for all of these, as a nurse, what do you think you need to do for these type patients that you have? How do you think you need to approach them?
Empathy, patience.
Yes. Empathy patients. We wanna make sure we eliminate their stressors, so finding out their stressors, what stimulate them, building that trusting relationship. We wanna explore their feelings about it. And maybe decrease caffeine and stimulant use would be really good, cause it hypes them up more. So these people are constantly on edge, usually. Piglet. So Piglet from Winnie the Pooh, Which one of the disorders do you think he has? The generalized anxiety disorder, yes. So this is like basically persistent anxiety over time, like it interferes with like their daily activities as well because they're constantly stressing over small little daily tasks. But it's not like OCD necessarily related. They can be restless, irritable, fatigued, difficulty concentrating on things, so maybe like bouncing around, sleep issues, because they're constantly like, well, what's gonna happen next? So as a nurse, what are some things we could do for them? I don't think that'll work.
Yeah, that one works for sure.
How
Deep
like-
breathing,
Yeah. Deep breathing, what else?
meditation, journaling,
Yes, deep breathing, meditation, journaling.
grounding. Yeah, grounding.
Grounding techniques help so much.
Mm-hmm. Like, what are some grounding techniques?
Like the,
You said what?
Laying up, like being outside.
And outside, yes. That's really good for them too. So maybe, journaling. Yes, so coping interventions for when they become anxious is really good. All of the ones that y'all have mentioned is really good for them to do. So Snow White cleaning up the dwarf's house.
That's OCD.
OCD, yes, OCD. So OCD basically is an unwanted, usually reoccurring and intrusive thoughts or images which the person tries to alleviate through like these repetitive behaviors, which becomes their obsessions and then their compulsions. So it could be of anything, like counting is a big thing, or like I have to, before I leave the house, I have to double check the bathroom, or make sure the stove is off. Like that was a huge thing, like my grandparents had a gas stove, and then they also had like a gas heater. So in the wintertime, they would go in and out of the house at least twice to just make sure it's off. It's like, you don't cook anything, like what are you checking this morning? So that was a bit annoying, but obsessions like that, they have to keep doing those tasks. Y'all know anybody that has OCD? Like true OCD?
Yes.
Definitely. What are some of the things that they normally do?
It's repetitive. My brother has it real bad, so, he's very a clean freak, and so everything has to be clean, like his colognes are in a certain spot, his clothes are color coordinated, and he can tell if somebody's like moved something out of his closet immediately.
Oh, wow.
Yeah, real bad.
Immediately.
Immediately.
So some of the things we do, behavior techniques, relaxation, deep breathing, meditation, imagery, music. Really good to have supportive groups. So if we decrease like their isolation. I don't remember the name of the movie. There's one movie out that this lady has to like clean all the knobs and she doesn't want to touch anything. Y'all know what movie that is? Like y'all seen
I
that?
thought there was a TV show.
It might be a TV show. Oh, Monk, yeah. It's- So also we can give them SSRIs, some of the MAOIs, just depending on what they need at the time. Most of them actually know that they have these obsessions, so we don't have to necessarily tell them. But we do need to identify like our biases as nurses with it, because dealing with a patient with OCD can definitely be frustrating. Because like I had this one patient, they were like, I need a medicine cup and this much water in that cup to take this many pills at this time. And I'm like, is this a joke? Like, I was totally thrown off, because I'm like, wow. But if that will allow you to take the medications and you're comfortable with that, let me just do it like that. We want them to talk about how they feel about it as well. And then we want to keep their physical health in mind. So if somebody's constantly washing their hands, like what are we concerned with? I can't hear.
Skin breakdown.
skin breakdown, if your skin barrier breaks down, then what are we concerned with? Infection, yeah, so. Having all sorts of infections, they think they're clean, but end up spreading more germs because they're washing away their protective barriers. And so this is just a cycle, just to show the image of anxiety, the compulsions, the release periods, sometimes from the negative symptoms, and that's where we wanna really focus on getting them to, the relief periods, but it's generally just keeps going. And OCD can definitely come from like, someone may not have OCD and then a traumatic event happens to them, and it can cause them to go into this OCD state because they wanna take control of their situation. So we gotta be mindful of that, of like abusive situations that have happened to people. So maybe even friends or family, 1 minute they're normal, maybe a complete slob, and next thing you know, they're like obsessed with everything being a certain way. So being mindful of, showing empathy and sympathy for that person and what they're going through. So who do y'all think this is? This is Mufasa from Lion King? PTSD, definitely PTSD for him or they. So this is common mental health condition that can develop from a traumatic event. It involves like they have symptoms of like flashbacks, anxiety. They could have negative thoughts or beliefs. They really like to use, what coping mechanisms do you think they like to use a lot? Distraction, what else?
Drugs.
Yeah, they do. Substance abuse. They like to suppress and repress their feelings and emotions, then denial of what actually happened. As well as this is huge in our like veteran populations most of the time, going to like war and coming back. So being mindful of those things if you interact with that patient population. Because they don't really want these memories at all, and so something you do may trigger this. So my great uncle, he was in all of these situations in the military, and so I had said yes sir to him one day, and he got in my face, so like he's 6'3", in my face screaming and yelling at me, and his wife had to calm him down, like, this is Tiffany, this is like your niece, like calm down, because that was a trigger for him. And I didn't realize that because he lives in Chicago, I'm from the South, we just automatically say that most of the time. And so that was a very scary experience. So you just don't know someone's trigger. So as a nurse, we gotta try to figure those out, like talking to the family if they have family, or if they constantly come into the hospital or into your clinic, getting to know them and see what they say and kind of figure out what it is. To have those positive experiences. I had a family member, like nightmares happen a lot in this population as well. He used to wake up choking his wife, and like, cause he had a flashback of like combat as a veteran. So this can be like pretty severe, or it can be mild. It just depends on the patient. So you definitely wanna figure that out if you're dealing with the mental health population, cause you don't know anyone's triggers. You gotta be aware, very aware of the triggers. So we would want to put them on like SSRIs like Prozac, Lexapro. We wanna make sure that they are doing like their regular activities, not withdrawn from everyone. We wanna provide a safe space in the appropriate setting for them to talk about the event. And you may have to have other people involved in that, depending on how they react to those triggers for your own safety. So eating disorder. So there are different eating disorders that we have. What do you think we could do for this patient that has eating disorders? As nurses.
Talk about their triggers as to why they're not wanting to eat or why they're, I don't know.
Yeah.
I'd help them talk about it.
We can talk about it. Definitely we want to know the signs. So what are some of the signs we can look for with eating disorders? Going to the bathroom?
Like
Immediately after eating.
Immediately after eating, yes.
just saying they're not hungry all the time.
Mm-hmm. Avoid eating with others. Weight fluctuations, so these clients, we might wanna weigh them frequently. We wanna watch like how much they exercise as well. They might be excessively exercising, they have to do so many push-up, pull-ups before they even eat a meal and so many after. They're so focused on like their food, their body shape, and their weight. Have like extreme like rigid eating rituals that they do. And the risk factors for this is like primarily female gender, as well as family. It could be social and psychosocial risk factors as well. And so, for anorexia, we have the restricting and we have the binge eating and purging. So restricting their own diet and fasting cycles. And for our binge eating and purging, they eat a lot and then they self-induce vomiting. So, this one has more of the highest risk for like mortality rates and psychological complications and suicide risk. Because they can have like acute cognitive dysfunction. But we have to make sure their weight, their normal weight is restored for all of this to like clear up basically. Because they can have like cardiac complications. They can definitely be life-threatening. Like prolonged PR intervals and QT intervals, T-wave changes. They could have palpitations, arrhythmias because of decreased potassium intake.
Are you saying that the bulimia and binge eating fall under like the umbrella of anorexia nervosa?
No, there's two subtypes of this, and kinda sorta, yeah, but not really, cause they're all diagnosed differently. But within anorexia, they have those two subtypes. Yes.
Can you repeat the, EKG changes?
So prolonged PR intervals and QT intervals. T-wave changes as well. Palpitations and dysrhythmias. And then they can have fluid electrolyte imbalances. So like the hypokalemia, hyponatremia are some ones that we wanna make sure we focus on. As well as our metabolic alkalosis, because of like the constant vomiting that they're doing. So, and then they could have metabolic acidosis because the reducing sodium bicarb related to like them using laxatives often. thing in this population is the refeeding syndrome.
Wait, do what?
Refeeding syndrome. So like when we're trying to introduce food back into their life in the appropriate manner, we have to make sure we monitor them very closely during this time period of refeeding. Because they could have, like, since they already have these electrolyte imbalances and low vitamins, we gotta slowly, which that's a little bit more detail, we have to slowly introduce the food. And this goes back to, like, this is a horrible time in history, but like the Jews in the concentration camps, a lot of them died when they started intaking food because they were intaking it so quickly that their body didn't have time to balance out. So,
And if someone's frozen, you can't just shock them.
Yeah.
Like you bring them back slowly to natural temperature. Right.
no, I'm talking about their food, like.
Yeah, I know. I'm saying when someone's frozen,
Oh,
you can't just
frozen.
shock them with suddenly, you have to bring them, their body core back to natural temperature. Slowly, the same way with food.
Yeah. As well. So bulimia, so they're basically eating a large amount of food in a short period of time. So we need to focus on like their GI as well as their cardiac system again. So like GI, we wanna see, they probably have a bloated abdomen, they could have GERD.
Wait, what was the definition you gave for bulimia?
Eating a large amount of food over a short period of time. And
That's a bit, well, I mean, bleeding can be done too, but then you have to do like purging, right?
That's when the,
oh, now I get what you're saying a little bit.
Yeah, the
Yeah,
umbrella.
Yeah, the umbrella. So this also is usually followed by purging as well.
Purge.
And so they binge, well, they'll binge and then they'll end up purging. But we're looking mainly at their GERD, and this one they'll use a lot of laxatives for bowel movements and have like the bloated stomach, the tooth erosion.
Are we talking about binge eating or bulimia?
Bulimia. So all of this kind of intertwines with these eating disorders. So the bulimia, binge eating is more like.
I thought bulimia was just like inducing yourself to vomit.
After binge
You don't have
So
to
binge eating, you're not necessarily vomiting after. They're just eating a bunch of food.
eating. Not during the like.
Okay, we're just gonna continue. Yeah. And so we're still looking at the same electrolyte imbalances with this. We're gonna supervise their mealtime still. They are like kind of on diuretics as well as the laxatives. Have body distortion issues here. They could have depression, anxiety. And so they're going through the yo-yo effects of eating a lot, then they'll binge, just trying to be in control of their situation overall. So we need to monitor their elimination patterns as well here. See if they increase or decrease. Then we have Winnie the Pooh eating his honey. So here, binge eating, they'll eat a large amount of food and they don't have like any behaviors such as like bulimia has, and it leads to a lot of weight gain in this population. So after they binge eat, maybe because they're depressed about something or a trigger from the past, they'll like feel guilty, emotional distress. They like to eat in private, isolate themselves. So we wanna establish a therapeutic relationship with this client. We wanna promote accepting non-judgmental environment. And they could have like high blood pressure, high cortisol levels, heart disease, obstructive sleep apnea. So we wanna make sure we set goals with this patient population. But we wanna allow them to still maintain like control over the types of foods that they eat and try to help them figure out the correct amount of food to eat. And then coping strategies for what they're dealing with emotionally, and maybe refer them to Eaters Anonymous. So we want to treat by interrupting the behaviors and aid in weight loss strategies. So we can actually use like Prozac for this, because they might be depressed, and that's the reason why they're overeating, or Vyvanse to treat. Because some of the side effects is like, appetite suppression. And so this kind of makes me think of like 1,000 Pound Sisters that's on like TV, definitely.
Can you give me the medications again?
Prozac and, Prozac and Vyvanse. Yes. And so for our anxiety disorders, we give analytics for it.
What'd you say we
For our anxiety disorders, just overall like the general anxiety, this is the, where we can give benzos as well. We could give beta blockers like metoprolol, a lot of people get put on. We already mentioned Prozac. Hydroxyzine, is an antihistamine, but you can use it for people with panic attacks. So we typically want to only use our benzos like PRN as needed, because we don't wanna create an addiction to it. So we need to make sure our patient is aware of like sedation, sleepy, suppression of their ABCs. They could have even seizures with this, so we wanna instruct them to stop the benzos that they may be taking. So for the buspirone, it's not sedating, you can still take it and drive. It takes time to work. We don't have create dependence or withdrawal effects on this. Actually, a lot of nurses take this because it doesn't have all the side effects that benzos typically have. So,
Ms. H, are you talking about the analytics for like eating disorders? You kind of treat the anxiety that underlines why they're having those eating disorders?
you can add that to the eating disorders, but any type of anxiety.
Okay.
So generalized anxiety, the OCD has an anxiety component, the PTSD does too. So people may be on multiple medications, anxiety medication, depression medication. It could be a variety, they mix and mingle. That's why at the beginning I stress that you need to know what medications your patient is on and why they are taking them. Because like, for example, this is off the topic of mental health, but like Viagra, they can take that for blood pressure issues as well. So you have to know, because the first time I gave it as a nurse, I was like, this is gonna be a long, interesting day. And then I looked up, like, oh, okay, they can take it for blood pressure. So you definitely have to know. and you see how you can use it for a variety of things.
What was the antihistamine for the pain?
Hydroxyzine. Yeah, so Angelina Jolie, which I was surprised, she actually had borderline personality disorder. I was surprised by it, because I was like, I looked it up, and I was like, oh, okay. Maybe a lot of celebrities do, at this point, right? So, this affects like how a person thinks, feels, and behaves, especially like in their relationships and their self-image of themselves. So they're emotionally have emotional instability, impulsive action, intense fear of like abandonment is like number one for them. So we wanna treat with psychotherapy. So there's not really any medications approved for this, but you can put them on like a mood stabilizer, antidepressant, antipsychotic. But we can't just put them on the medication. We have to combine like talk therapy, coping mechanisms, all of this. Like, just because they're going to work, they're not abandoning you.
Is it usually comorbid with something else?
I would have to look that up.
Cause you're talking about antidepressant.
Well, they have an anxiety, they're in fear of being abandoned. They'll like my example, somebody's leaving to go to work and all of a sudden you think they're never gonna come back. That's very unhealthy and it kind of like anxious, so yeah. So we want to make sure we have their family involved and educate and have peer support groups for them as well. So from The Good Doctor, has anybody seen the show? Okay, so what do y'all make of when y'all see it? Yeah. So autism, so what's some nursing interventions is needed for this time?
You need private room for self-stimming.
Is that a private what?
Private room for self-stimming.
Yeah, private room for self-stimming. Anything else? You said what?
They're triggers, cause they also have triggers.
Yes, they're triggers. Somebody else says something.
Good communication.
Good communication. So knowing the best ways to communicate with them. So we wanna assess their verbal and nonverbal abilities. We wanna use visual aids, simple language, allow for extra time for responses. But it is a spectrum, so we have to figure out and identify them as an individual. So like their behavior patterns. We need to monitor for repetitive behaviors like rocking, hand flapping. We need to find the best coping mechanism for them and maintain, like for all of them, a constant routine. Like routine is key. Yeah, consistent routine. Yeah.
Predictable.
So we wanna also identify like their sensory processing, like their sensitivity to like light, sound, touch, cause that could trigger them. Even textures is a thing for them as well. And some people have autism and they're on the high end of the spectrum and you barely even notice it. So we wanna make sure we know like their self-care abilities with autism, how independent they are, cause we don't wanna take away their independence when they're in hospital. We wanna establish like trust, positive reinforcement, collaborate with the family is very key, or whomever is taking care of this patient at home. We wanna avoid overstimulation and sudden changes. So when they come into the hospital, we don't want to divert them from their usual day at home. We have the this one patient on the floor I did work on, and we had to keep the same sitter with him. And if he didn't have the sitter with him, he would beat his head against the wall, or he would punch himself in the head, so he had to wear like a helmet when he's up moving around. We have to wrap him a certain way. So, and he's nonverbal, so he can't tell us what he wants, so we gotta go through the pudding, whatever, to figure it out. So in procedures, we wanna make sure that everyone's aware of this person having autism and how to best deal with them, cause they may go downstairs for a CT scan or something and start freaking out because it's normally closed. We might need to do an open one. We might need to see if a family member can come and be in their visual, like, they can see them. And then TV show Mom, I don't know if y'all seen that before, but it's basically about, a mom and a daughter that both have substance and alcohol abuse. So, this can affect like all ages and cultures and social economic classes. So basically it affects their central nervous system as well, and it changes like their mood, their perception, and behavior. In their mind, they're in this euphoric state of mind, but in reality, they may be putting themselves in danger. So, also when you have substance abuse, you have like unhealthy behavior, so you're not eating as much because they don't feel hungry. They might have hypersomnia or insomnia, depending on the medication that they're taking, risky practices in general. So I don't know, do y'all remember, it was over the summer, a lady got hit and killed on the interstate. She was, on 65, she was homeless, people knew she was homeless, but she was on drugs, and she walked out into the interstate. So, having to be aware, and then really knowing what drug they're on too, because people withdraw differently, and it can be very dangerous, because we do give them, some of these people, when they come into the hospital to withdraw from whatever substance it is, they know the criteria to get the benzos, because we give a lot of Ativan when they're coming off of the drug in general. And so some common substances would be like alcohol, y'all know, opioids, street drugs, like there's this drug called Trank that's it's really still over toward Portland, Oregon area. Basically sloughs off your skin. It's like fentanyl and horse tranquilizer mix or something like that. Trank, like TRANQ. Yeah. And there's another one, I had a patient earlier in the year, it starts with an N, but I can't remember, it's coming from like New York. A lot of celebrities are taking it, and so you have to set a timer on your phone that you wake up and take it, or you automatically go into withdrawal. Yeah. So we need to really know what they're on so we can appropriately treat them. So the Wernicke-Korsakoff syndrome mainly is what we're treating a lot of times in our patient population, because it's basically thiamine deficiency. So we're like giving thiamine about 3 times a day to this patient. Yeah. Thiamine. Yeah. Yeah, 2 to 3. Yeah, 3 times a day for 2 to 3 days, along with the Ativan usually, because this can be very life-threatening if not treated.
You said giving vitamins 2 to 3 times a day?
Three times a day, 2 to 3 for 2 to 3 days.
Okay, like a week?
Yeah, sometimes longer, but usually that's just like the basic standard. So we wanna treat this early on. So this patient could be like confused, have loss of coordination, like some abnormal eye movements. They're delirious, can have some hallucinations. It could cause like atrial fibrillation in this population, so that's another reason why we wanna go ahead and treat immediately. Yeah. So, yeah, and then they can, we hear about them having cirrhosis, pancreatitis. Most time when they come in with pancreatitis, I know it's alcohol abuse. We do have some fetal alcohol syndrome in pregnant women. And then there's some hospital complications that can happen as far as like respiratory, like if they're going down for a procedure and we don't know that they're abusing drugs. So we wanna definitely do a drug test on them beforehand because we don't wanna overdose them. We wanna make sure that their blood glucose is in range. Also, folic and magnesium deficiencies happen with this population. And then hypokalemia, so potassium can be low for a variety of reasons in our patients, and we wanna make sure that's within range. And so here's just a time frame, just to give you more of a visual that you can review, as well as with opioids withdrawal time frame and what it does to your body.
Can you please tell us what splitting is real quick?
So splitting is just going from one extreme to another. So I love you this hour, and then the next hour I hate you.
So like a more progressive bipolar?
No, splitting is just term. Yeah. It's just splitting. Well, I'm trying to just make some of the stuff. Yeah. So one of the examples, okay, so for splitting, since there's some confusion, one of the examples I gave one time was a person prays a friend as a best friend, and then the next day they call them a manipulator.
Okay,
So that's,
I remember that one.
yeah.
The last name of this place,
She erased her board.
The one about the kid that came to the hospital that spoke random words, what was that?
Random word.
Like the mom brought, the 12-year-old, yeah, to the hospital and then it was.
Yeah, so ADHD. So a lot of times they don't allow you to finish your statement before they answer. Any other questions? Hey, they're asking questions, so your test is failing. No, sodium, I had talked about sodium extensively with schizophrenia, hyponatremia. The sodium levels, you take the lithium, all of that can be off. Yeah, but for the sodium level to be off in schizophrenia, that completely turns them off. So bipolar, if they're on the medication, yes, but schizophrenia regardless, if their sodium is off, they are completely lost. Most pleasant way to say that.
which one was the one about the guy coming into work like all sad and stuff? I was like, I don't have depression.
So that's bipolar depression. So you notice I didn't put depression on here, so you have to know that's part of being bipolar. Cause the mania and then the depressive episodes.
Let me go back to the, when you're saying that it was schizophrenia that have the low sodium, is that just the psych meds or schizophrenia?
Just schizophrenia in general, yeah. Okay, so Dr. Hicks is here.
Alright, so we're moving on to immune inflammation and cellular regulation. So to start off with that, let's just kind of talk about some terms that we're gonna be using a lot of times. So we've got immunocompetent, everything's working like it's supposed to, immunocompromised. We have several different disease processes, alterations that are gonna cause immunocompromise. And we've got a worksheet that we're gonna start working on here in just a minute, because I really feel that if you can tie what the cells do, then you can understand the disease process a lot better. And you can understand what's going on with that disease process. So what are things that make your immune system work well?
Nutrition.
Good nutrition. So on the flip side to that, garbage nutrition makes your immune system not work well. So good nutrition, perfect. What else? Exercise. Exercise, exercise, exercise helps your immune system work at its peak function. And again, the flip side to that, having a sedentary lifestyle makes your immune system not work well. What else? What's something non-modifiable?
Genetics.
I didn't hear what I heard. What was that?
Genetics.
Okay, genetics. So if you have some sort of genetic issue that may cause you to have some disease processes. What's another one?
When your immune system fights itself, attacks itself.
So disease processes in general. So we've got autoimmune diseases, we've got cancer type diseases, so we've got a lot of diseases that attack your immune system. What else? Non-modifiable. Somebody said it. Say age. Yeah. Age. So when does your immune system work at its peak function? Anybody got a guess? We're gonna do like decades. 20s. Your peak immune system. So those of you that are in your 20s, congratulations. It's a downhill rolling slope from that point forward. So
1 year away from the immune system.
if you hadn't hit the 20s yet, which we may have a few, you're on your way to the top of the hill. And then it just goes down from there. So we do worry with our immune system with our very old and our very young. They do not have as good a functioning immune system as our young adults do. Y'all are really testing my mental health with this. We will fix this on break before I have a complete meltdown. So in our age range, 20s, we're going to have a good functioning immune system, and then we're just going down. Okay, so those are our good non-modifiables. What else helps your immune system work well? Or let's say what makes your immune system work poor, if that kind of helps you think that direction a little bit more. All right, lots of medications. That kind of goes with nutrition, like our vitamin deficiencies. As we said, poor nutrition usually is poor vitamins and minerals, antioxidants type stuff. What did you just say, Carson? Drugs. A lot of medications. We are going to cover chemotherapy and immunosuppressants as part of our drugs that are going to make your immune system function not as well. What else? Lack of sleep. So lack of sleep causes so many different problems. So lack of sleep makes your immune system not work that great. Also causes massive mental health issues. And your mental health is directly tied to your immune system. So the one y'all haven't said yet that y'all are completely under is stress. How many of y'all gotten sicker since you started nursing school? Yeah. High stress leads to sickness. So having those good coping mechanisms to protect your mental health actually protects your immune system as well. What's our first line in our body for our immune system? First line of defense. Your skin. First line of defense is your skin. This will come into play a lot later when we go over burns at the end of the semester. So your skin is your first line of your immune system. That's going to include your mucous membranes, all the functions of your nose to try and protect. And then we get into second line, which is the worksheet that we have that we're going to work on. What are normal age we said age, your immune system kind of goes down. What are some normal age-related changes when it comes to your immune system? What kind of happens?
Skin changes.
Okay, you can have skin changes, which means it's easier to break, it's easier to tear, easier to just have some broken areas. What else is normal age-related function with your immune system? Like, why does your immune system get poorer the older you get?
Nutrition.
Not really nutrition, because that's something you can control. No. No. Dehydration is something you can control.
What about metabolism?
All right, so your metabolism starts to slow down, so you may not process your nutrition as much, which again is kind of something you control, because then you just increase how much fruits, vegetables, and antioxidants that you eat. So we have to make some changes to account for that. Yeah, your bone marrow just slows down. So all of these cells that we're about to go over come from the bone marrow. So the bone marrow produces all these cells. So it is a normal age-related thing that we just start producing less of the cells. We just stop making it. As we get older, one of the cells that's on here is a memory cell. Well, memory cells only have a certain lifetime. They live a very, 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 very long time, but they just kind of die off and stop. So that's a normal age-related change. This is why as we get older, you guys see the commercials and you guys know it, we need booster shots as we get older. So you may have been immune against something when you were younger, whether it's from interacting with the disease or getting a vaccine, but as you get older, you need those booster shots because your memory cells just aren't there like they used to be. So we're going to classify some immunity. You have 4 different basic types of immunity. There's definitely specifics, there's exceptions to these rules, but these are overall generalized categories of immunity. So we have natural, we have artificial. Some literature may say instead of artificial, adaptive. So you may see that term. I think your book has artificial instead of adaptive. And then we have active and we have passive. So if we go natural, active. So if you think of natural, active immunity, what do you kind of think of?
You get sick, and then your body makes the antibodies.
Yeah, you get sick. So one of the classics is chickenpox. So people my age and around my age, we didn't have a varicella vaccine when I was a kid. We had chickenpox parties. So you would go down the street to the kid that's got chickenpox. You get chickenpox when you were little. Congratulations, you're now immune to chickenpox. Yes, really happened. 7 years old. Chickenpox party. Went down to it. Because when you're a kid, you can battle chickenpox a lot better than when you're an adult. Because when you're an adult, if you battle it, like it can be life-threatening. It can be very dangerous. So natural active immunity is you come in contact with something and you now have developed immunity. This is why COVID was such a challenge for us because we had never come in contact with it before. So none of us had any natural active immunity against it because it was a new virus and we hadn't been able to experience it. This is how we get herd immunity. If we all can become exposed to it, we can get, you can also get it in another way too, but this is kind of the best way. We can all get immune to it and then the disease is eradicated and we don't have to deal with it anymore. Another way we can have natural active immunity is just us as a human species. Like we don't get feline AIDS. Like that's not a thing. We're not going to get diseases from other types of species. That's what makes it really dangerous when some of these bird pox and those types of diseases start to mutate to get to humans. Because we have a lot of immunity just being a human that we're not going to get some of these diseases that animals might die from.
So is that like swine flu and bird flu is a bunch of BS?
As long as it doesn't mutate, because there's been a few cases where there's been some mutations going on. So that's where it starts to get scary. But right now we're protected from a lot of that because we're humans. All right, so natural active, is this gonna be temporary or lifelong? Lifelong. All right, natural passive, what you think of? Breast milk, so it's natural, but it's passive. Your body didn't do anything to create this immunity. So lifelong or temporary? It's temporary. That's why Board of Pediatrics recommends breastfeeding for up to 2 years, because you're going to give that child 2 years worth of mama's immunity. So baby's protected from the immunity that mama already has from all the diseases that she's been exposed to. So this is temporary, it is natural, and that's the most common way we think of natural passive is going to be breast milk.
Can you repeat the definition for it? Your body doesn't what now?
Your body doesn't make the immunity, so it's passive, but it is natural because it's mama's breast milk transferring to baby. All right, artificial active, what do you think? Yeah, this is our classic vaccine category. So it's artificial because it's going to be made up in a lab, but it is active because your body is then exposed to this disease. So like instead of me being exposed to a kid with chickenpox when I was 7, you guys may have had a varicella vaccine so that we get the same level of immunity. It's not as good as natural active, however, still lifelong. Can be a lifelong immunity. Both of these, this is why a lot of times our older folks need to get those booster shots towards, a little bit later in life, because of that natural, just age-related changes. All right, and then artificial passive. What do you think that is?
Antibody injections.
So these are going to be your antibody injections. These are going to be like a post-exposure type situation. So if you did not get the hepatitis B vaccine, but you were exposed to hepatitis B, we can give you antibodies against hepatitis B to try and protect you from contracting that disease post-exposure. So it's going to be those antibodies, and on our worksheet, it's going to be the IgGs. So when we get there, we'll fill that out. But that's where we're going to get those antibodies to try and protect us from an exposure that's occurred. So is that temporary or lifelong? Temporary. So basically anything that's passive is going to be temporary. Anything that's active is going to be lifelong. I do have to throw in because it always comes up like the flu vaccine. That one is temporary, but that's because that virus mutates, like crazy. So there's no way we can develop a lifelong flu vaccine because that virus mutates so rapidly and so fast. So that one's not a lifelong vaccine for that reason. But a lot of our other ones are lifelong, or they have a long shelf life. Like MMR is, some of you guys may have experienced that where you may have needed a booster already. So, a lot of our vaccines fit into this, but remember I said there's always like little exceptions to the rule. All right, you do not have to know this, so please don't try to memorize it. This is an example cell, or example slide of how we get all of our cells. So who produces that stem cell up there? The bone marrow does. The bone marrow produces a stem cell. How does the stem cell know what kind of cell to turn into?
Magic.
The magic. What's the magic? Jesus gives us the stem cells to start with. Creation. Our body tells what cell it needs. So if you're really anemic, because we already did kidneys, if you're really anemic, your kidneys are going to produce what? Erythropoietin. That erythropoietin goes up to that stem cell and goes, hey, I need you to be a red blood cell. And the stem cell goes, okay, I'll be a red blood cell. So your body sends off all of these different kind of messengers, different kind of feedback to tell that stem cell, hey, I'm low on helper T cells. Can you make some more, please? Thank you. And then it will divide into. So that's why I like this slide, because it shows that a stem cell can literally turn into any of the ones that we need. It's based on the feedback from our body. All the different hormones from our body, We're gonna say the word cytokines in just a little bit. Cytokines are just messengers. Hormones are a type of cytokine. It's a messenger that tells your body what it needs. Which brings us to our worksheet that I have given you. So on the front page of this worksheet, I'm gonna give you like 5 minutes, because again, I don't like you guys using Google or Notes at first. Like, see what you actually know. Then we're gonna answer all the things. You are not gonna know a whole lot of these, I realize that. But I wanna see what you can kind of trigger your memory and see what you might remember from A&P, which for some of y'all wasn't that long ago. For some of y'all, it's been a very, very long time ago, so I understand. See if you can remember anything about what these cells do. Obviously, we're going to go over all the answers. So, see if you can remember what they do. I'm not going to give you that long, so I'm not going to torture you. And then we're going to go over what all the cells do. Then we're going to try and tie basically all of our exemplars to one or more of these cells. Okay? So, like 5 minutes, go down the list and see if any of them you remember anything about. All right, did y'all get one? Did you get one? Yay! 2? Maybe? 3? Started getting quiet. 4? Wait, is that a total shutdown on 4? Yeah, I don't want to go that far. All right. So we're going to start off with our phagocytic cells, which are the first 5 that you have listed here. So phagocytic, what does that word mean? Eating. That's why I made it Pac-Man. So if you think of all the little dots as the germs, the little Pac-Man is your phagocytic cell. He's going through and just eating up all of the germs. And these are types of phagocytic cells. They do some other things too. But they're going to go through and they're going to eat up all of the virus, bacteria, dead cells that need to be eliminated out. Like they're going to go around and they're just going to eat up those cells that need to be processed out of the body. So that first one, neutrophils, did y'all have something written for that one?
It's the most abundant.
Okay, that one usually at least 1 or 2 people have something. That is the most abundant cells. So our neutrophil count is our most abundant white blood cell. So have y'all seen on a CBC report, a CBC with diff? So if you see the differential, you're going to see these cells listed on that differential. And it's going to give you percentages of how many each one of these cells we have. So neutrophils are the most abundant. We have the most of these. We produce a ton of neutrophils, but they die really fast. So we got a bunch of them, but they got a short life. They work hard, they die. This is the one that causes your white blood cell count to increase when you have an infection going on. So when you have an active infection and your white blood cell count goes up, it's because of these guys, those neutrophils. Have you guys seen a lab value called an ANC on a patient? Okay, so be kind of on the lookout for that. That really is something that we do with immunocompromised people. So you're going to see it on like cancer patients, HIV patients, autoimmune disease patients. You'll see an ANC. That's an absolute neutrophil count. And so it's just giving you a little bit more detailed of a picture about what's going on with their immune system. So instead of just getting a basic white blood cell count, you would get an absolute neutrophil count. So just more pieces of the puzzle to understand what's going on with your patient. So if you see an ANC, that's what that is. All right, so like I said, lots of them die quickly. Macrophages. Any clue on macrophages? They're all phagocytic. They all eat. All right, so macrophages, the word macro, they're really big cells. So they're really big. These guys, they live for a long time, so they got a long lifespan. So neutrophils die fast, macrophages live for a long time. One of the biggest functions of macrophages is they are the messengers. They send off cytokines. Cytokines. cytokines, cytokines. Cytokines are those messengers that tell the rest of your body, hey, I'm fighting an infection, I need help. So cytokines are messengers. So when we get into our medications, some of the cytokines that we're going to talk about is tumor necrosis factor, or TNF. Have you guys given any drugs that are anti-TNF? All right, so they're very, very common in like lupus, arthritis, psoriasis. So there's a lot of commercials out there for all these different, like Humira, Skyrizi, stuff like that. They're anti-cytokines, so there's tumor necrosis factor, there's interleukin, INTERLEUKIN, Luke as in like leukocytes. So a lot of our medications that we're going to talk about that are for lupus, arthritis, stuff like that, are actually going to inhibit the cytokines that macrophages release. So it's a big function for them. Monocytes really don't do much of nothing.
Sorry, what did you say stops the, or inhibits the macrophage?
A lot of the medicines that we're going to talk about will inhibit the cytokine release that macrophages do. So those cytokines that the macrophages release like stimulate inflammation. So if you want to write that down, like macrophages stimulate inflammation. And a lot of our medications are going to decrease inflammation, so they kind of block those. So when you're looking over on that second side over there, the disease, you can put over there like a lot of medication classes, and we'll fill that in next week. Monocytes, they're baby macrophages. They don't do much. So we're just going to skip right on past them. We're going to kind of combine eosinophils and basophils. These two guys are very, very similar. Their main function is releasing histamine. So if you hear histamine, what do you think? You think allergies, yes. So these two guys are very highly active in allergies because they release histamine. So eosinophils starts with the E, allergy, kind of think of it that way. So these are going to stimulate all that inflammatory process as well because of that histamine release. All right, B cells. So on your worksheet, we've got B cells. So we've got antibodies and we've got memory cells. So the first one on your list that you have is a memory cell. So let's kind of talk about what happens when a B cell is triggered. So you've got all these B cells floating around in your body. Let's go back to the chickenpox example. So if you are exposed to chickenpox, that B cell is going to come in contact with it, immediately divide into two different cells. It's going to divide into an antibody, one of these options, and attack it. Then it's also going to divide into a memory cell that says, you know what, next time I see you, I don't have to divide, I'm going to kill you right now. So when you first come in contact with the disease, the B cell is going to split into two. One to attack, one to remember you. The second time you come in contact with that same disease, that process don't have to happen. These memory cells already know you. They're going to attack and kill you right off the bat. Does that make sense?
You said one splits to what?
So when you first come in contact with the disease, the B cell is going to split. One cell to attack, one cell to remember. The second time you come in contact with that same disease, these ones that remember you, those memory cells, they're just going to attack. And they're going to kill you on the spot. So memory cells are going to float around just remembering what disease they came in contact with before, and they're going to kill you. So this is a big part of our vaccination status, like trying to train these B cells with new memory cells so that we attack quicker. So a lot of our vaccines kind of use this process in order to create that immunity, because we're trying to create memory cells. All right, so each one of these antibody options. So we got a lot of these. So IgG, that one is the most common one. We see that one all the time. In fact, we give IgG. Has anybody had, or did y'all learn with multiple sclerosis, giving IgG? So that's what this is. It's just B cells that are ready to attack, ready to kill those abnormal cells that are functioning, or ready to replace those abnormal cells that are functioning. So IgG is our most common antibody. IgM, that one is the first responder. So that's the one that's going to split into initially, like to go ahead and get that first attack out of the way. So IgM's first line of defense. IgG is like the massive swarm that comes right behind it to finish off the job. All right, IgM's first line. IgG is the army coming behind them. All right, IgA. Anybody know what that's in?
Breast secretion.
That one's in breast milk. So IgA, so remember we talked about that natural passive immunity? This is how we get it. Mama's IgA. IgA transfers in breast milk to baby. IgD, nobody really knows what it does.
That's the only time we see it.
Pretty much. IgD, we don't really know what it does. Just go skip around on it. All right, that's the monocyte of this one. We don't really know. It does something, but it's like every time you look it up in research, it's like function is unclear. So we're just, it's there, so we're gonna put it up there. We're just gonna skip right on by it. IgE, there's another E, so allergies. So eosinophils, IgE, allergies, all of that has to do with our allergy function and histamine. All right, so this is how we create a lot of treatments. So when we're talking about our medications that are monoclonal antibodies, y'all heard that term? That was really big with COVID, because we would treat with monoclonal antibodies. Okay, so when we talk about our medications, this is what we're talking about. We're kind of creating antibodies. All right, the most fun one is the cell-mediated. So these are last, what, 4? Yeah, last 4 of our cells. All right, helper T cells, CD4 cells. Do y'all got anything for this one? This one sometimes y'all kind of know.
They bring it to someone.
The what?
I thought, don't they bring it to someone that eats it?
Kind of.
They release the cytokines.
They're the flaggers, yeah. So your helper T cells, these guys float around the body. They don't kill anybody. So first off, they don't kill anybody. But they mark everybody else to be killed. They're like the little spies. So they're going to go around and they're going to mark foreign bacteria, virus, parasite, fungus, like so foreign invaders. They are also going to mark mutated cells. So if I say mutated cells, what do you think of? Cancer. So any cells that have mutated, they're going to mark the body to go kill those too. So they're trying with to prevent cancer. So a helper. So if I'm a helper T cell and you guys are all cells floating around in the body, I'm just going to go through and say, you're me, she's okay. You're me, she's okay. Not me, y'all kill her. I don't like her, kill her. You're me, you're okay. You're me, you're okay. You look a little weird now, you changed. You're not the same as you used to be. Just kill him too. You're me, we're fine. That's literally all it does. It says, you are me, you are not me. You look like you've always looked, or hey, you look different, go die. So, trying to protect us from foreign invaders, whether it's bacteria, virus, fungi, parasite, whatever. And and also cancer prevention. So it's gonna kill off all those cells to try and stop cancer from being proliferated. Our main disease that affects helper T cells is what? HIV and AIDS. HIV and AIDS attacks exactly one cell of the body, the helper T cells. No one dies from AIDS. They die from the cancer or the infection that takes over and their body can't fight it. So AIDS doesn't actually kill you. It's the lack of helper T cells that does. Because then your body can't go around and say, that's an infection. So the rest of these cells, like the ones we talked about, the neutrophils, the monocytes, the B cells, all those cells are dumb. They don't know who to go kill unless the helper T cell tells them to do it. So if the helper T cell doesn't flag a cell to be killed, all the cells we've talked about are just like, I'm having a fun time, and they don't do anything. So these guys are extremely important. It's the only way your immune system knows to function. So big HIV/AIDS. All right, cytotoxic T cells. These guys are really cool because they float around, find one of the cells that have been flagged, poke a hole in it, drop a bomb in it, and the cell blows up. Cytotoxic. So, these are your bombers. Blow them up from the inside out. And then they float on to the next one. Of course, another flag cell. It's got to be a flag cell from a helper T. Natural killers is what it sounds like. These are your one and only cell that don't have to be told who to kill. So when we have our HIV and AIDS patients, these are the only cells that your body has for an immune system. They're natural killers. Nobody's got to tell them who to kill. They float around, they know, whoop, you need to die, and they kill those cells. The problem is we don't have enough of these. We've only got a few because we have all these other cells that function in all these other ways, so we really don't need a whole bunch of them on a normal basis. All right, and then our last little guy down here, suppressor T cells. These are the buzzkills, the party stoppers. They're the ones that say, stop it. The infection is dead. Go home. Quit killing people. The infection's over. So if you don't have enough of these cells that tell your immune system to stop, what kind of diseases do you have? Autoimmune diseases. Because all these cells are made to kill. They're made to destroy. So if you don't have somebody telling them stop, they're just going to start attacking healthy tissue. Because they have to have somebody to tell them to stop. So your helper Ts are the starters. Your suppressor Ts are the stoppers. So you see how all these cells kind of come into play. If you understand how they function, you can understand how the meds work, how the diseases attack you. All right. On the other side, on the other side of your paper, we are going to put together a care plan. So this one, if you'll draw a line down the middle, we're going to do hospital and home. So just draw your line down the middle because we're going to do hospital and home. So what I want you guys to come up with your friends and your buddies, come up with a care plan. So if you have someone in the hospital that is immunocompromised, these cells are not functioning as they are supposed to, we're going to say their white blood cell count is 0.2. That's horrible. Your white cell count should be what? Should be 4 to 10. So we're going to say their white blood cell count is 0.2, which is basically non-functioning. What are you going to do to take care of that patient to protect them while they are in the hospital? So we're going to come up with some things that we're going to do for this patient while we're in the hospital. And then a lot of these patients have to go home. in this state. If we're talking about somebody who's in an AIDS crisis that may not need hospital, they're getting better, they're going home. We're talking about somebody on chemotherapy with cancer, you know, they're going home. We're talking about somebody on immunosuppressants that's got like arthritis or lupus, they're going home. So they're going home in this immunocompromised state. What are we going to teach them to protect themselves when they go home? So what are we going to do in the hospital for them? What are we going to teach them when they go home? A lot of this stuff's going to kind of cross over and hit both sides. But see if you can come up with 10 things for hospital, 10 things for home, then we're going to put it up on the board together. And that's going to be our care plan for somebody with AIDS, somebody on chemotherapy, somebody on immunosuppressants. Like a lot of our exemplars, this care plan is going to apply to them. So come up with 10 things on each side, and then we'll see what all y'all came up with. All right, y'all ready to start putting stuff up on the board so we can get out of here for lunch on time? All right, tell me something we're going to do in the hospital. What y'all? I refuse to write anything other than the first line. Oh, I want the biggest one, the most important one. Thank you. I don't know what that was. Wash hands, wash hands, wash hands, wash hands, wash hands. Wash hands. And wash hands some more. Use your hand sanitizer. If your patient has what disease process going on, is hand sanitizer a no-no? C. diff. Thank you. You wash your hands with C. diff. Wash your hands, wash your hands, wash your hands, and wash your hands some more. So you will get fussed at in my clinical if I see you not washing your hands with hand sanitizer. And I'll give you the look. Wash your hands. Okay, now we can continue. Go ahead. All right. Neutropenic precautions, and we've got to define what that is because that's nice, big, pretty words.
No fresh flowers.
All right, no fresh. I'm gonna say plants, so that'll include our flowers and our ferns and all of those different things. So no, why can't we have any of that?
Bacteria.
Yeah, bacteria bringing the outside to the inside. So, all right, what else?
Masks.
All right, masks for who? All right, masks, gloves. There we go, PPE for the workers. So when we go into their room, we're going to gown up and we're going to glove up and we're going to, after we've washed our hands, if the patient leaves the room, then they are going to mask up as they exit the room. So when we walk in, we're going to use PPE for us to protect them from our germs. Okay, what else is in there? I'm going to put all of my hygiene stuff on home, even though it applies to both. So let's just go hygiene, and we'll come back to that because that's going to apply to both sides. What else is under neutropenic though?
Like paper trays.
Oh, the disposable stuff. Not every hospital does that though. There's one about drinking liquids.
We don't share with people.
That one kind of goes on both, but there's a specific one for neutropenic.
No fresh fruit.
Okay, that's not the one I was thinking of, but it belongs on here too.
No raw meat.
All right, let's actually, instead of saying no fresh fruits, let's say cook all things. So we don't want raw stuff. We don't want stuff that's been undercooked. We can't have like good sushi. We can't because that's in a hospital. We don't need fresh fruits. We would need like cooked fruits, so cooked apples, stuff like that. We don't want fresh apples. So nothing that may have foodborne bacteria, parasites, stuff like that. So everything needs to be cooked properly and completely. So that kind of encompasses a lot of different things. What's else about drinking? Your liquids.
Stay hydrated.
We gotta stay hydrated, but there's something we gotta avoid.
raw.
Um,
Unpasteurized.
They can't have that water jug just sitting there. So they can't have steam, like just, you can't refill their water jug and just sit it in their room. So water, if it's not covered and sealed, is only good for an hour. So if they've got a water bottle that they're tightening back up, like this is a no because it's open to the air. But like if you put this cap on and cover that, that would be fine.
For an hour.
They just need fresh water. What?
You said if they covered it, would be fine for an hour.
So this would be only good for an hour. Like then I would have to dump it out, clean it, and get a new one. Pseudomonas grows in an hour. So, but our immune system is healthy enough to fight it off because it's a pathetic little bacteria. And our immune system kind of laughs at it, like, that's funny. But their immune system obviously cannot. So, y'all taking micro? Some of you? Y'all grown Pseudomonas yet? We used to do that, some classes do. So, Pseudomonas grows in standing liquids, so no standing water, they don't get the jug, you gotta get them fresh stuff every time or give them water bottles that they can seal back up. Okay, what else can we do in the hospital for these folks? Okay, so I'm kind of coming out of neutropenic now. So we'll say limit visitors, so they don't need to have a room full of people, 1 to 2 max. Who should not come? All right, no kids, no sick people, and no people who have had recently a live vaccine. No live vaccine people until that time frame is over with. So that kind of goes into the sick people category. No kids, no sick people. Obviously, if your patient's got kids, we've got to make some exception to that because I'm not going to say you can't let your patient's kids come see them. But we just want to be very cautious, very aware. We want to teach the kids about washing their hands, wearing a mask, and don't crawl on the floor and then love on mommy. Because that's what they do. All right, what else are we going to do? Okay, private room. Thankfully, most of the rooms here in Alabama, most of them are private. Not always the case though. What else?
Aseptic technique with IVs, ports, shots.
Okay, so we're going to say protect all portals of entry. So that's going to cover your Foley catheters, your IVs, your central lines, your drains. So anything that is a portal of entry, we want to make sure that it is clean. If it's supposed to have a sterile dressing on it, it has a sterile dressing on it. We want to avoid, if possible. So we talked about on our previous test, reasons that you would have a Foley catheter versus reasons you would not have a Foley catheter. So if we can avoid portals of entry, if we can avoid Foley catheters, if we can avoid central lines, that would be preferable. Let's talk about central lines with our CLABSI prevention. So I'm going to put that on here. What's a CLABSI? Central line associated bloodstream infection. So we got to do our CLABSI prevention. So we talked about CAUTI prevention with the previous test. So we're going to talk about CLABSI prevention on this test. Our CAUTI prevention is still up for grabs on this test because it's all immune related. Okay. So CLABSI prevention. Let's say we've got a central line right here in the intrajugular, internal jugular section. What are we going to do to keep this protected? All right. So we're going to keep this dressing sterile, intact. So if your dressing has come lifted, what are you going to do? You're going to change it with sterile technique. Get your sterile gloves on, you're going to change that dressing. There's a certain product that you can put on there to try and keep it sterile and intact. You might know what that product is? So either Skin Prep is kind of the generic name, or Mastisol is a brand name. So you want some sort of adhesive to try and keep that intact. What was the? So skin prep is what a lot of hospitals use. At Grandview, we have Mass Dissolve, so it's one of the few things that sprung for the big bucks and got the brand name of the adhesive. But skin prep is one that's, it's very, like when you put it on your patient, it's very sticky. So it's gonna keep that dressing intact. We also are gonna have on there, so it's not just a Tegaderm, is it? What's underneath that Tegaderm on all central lines? The little bio patch, the little circle thing. So a bio patch is gonna release antimicrobial properties. You will use the bio patch. Some of the central line dressing kits, like the bio patch, is actually embedded into the Tegaderm. So it depends on what your hospital has. So either the bio patch embedded Tegaderm or the bio patch. Let's say that dressing stays intact. They never stay intact for this long. But if they stay intact, how long can they go before it just needs to be changed? 7 days. So if it hasn't been changed in 7 days, it's got to be changed at that 7 days. But don't nobody's central line ever stay intact for those 7 days. Usually have to change it every 4 or 5 because it comes flapping in the breeze. Especially with our fellas, hair growth. So guys, shave them before you put on that Tegaderm. You know, if they're doing all this business, it's just hard to keep intact. That's why our PICC lines have a less infection rate, because we don't have hairy arms right here. The dressing can stay intact better, and it's not, you know, as movable. So PICC lines have a much less infection rate than our central lines do. Okay, now what else are we gonna do for this person?
Should you make sure their vaccines are up to date or done that one?
I think that's gonna go more on the home side, so. Okay, fine. I'll just go ahead and put it up there since. What else can we do in the hospital?
Would you say, like, I mean, I know you said nutrition was gonna be more at home, but like in the hospital, like, ensure and just making sure the nutrition is good.
I'm gonna go ahead and put that here, because it applies to both. What do they need to have a good functioning immune system? Nutrition-wise. Alright, so we need good protein, helps with healing. What else? So we need calories. I'm gonna make it bigger. Let's say vitamins and minerals. To make it more broad so we don't list all of it. And I'm also gonna say antioxidants. Get the blueberries in there that I love so much. Oh, that didn't work. That's fine. Okay, what else can we put over here?
Reverse isolation.
That actually is what this is. So we'll put that in. Because that's the more kind of lay term for it, but that includes all that. What does it say? Reverse isolation. Same thing as neutropenic precautions. The words are used interchangeably. What else are we going to do in the hospital?
4% CHU for the CLABSI.
Do it now?
4% CHU for the CLABSI.
So that will be the biopatch. And then you clean it with either CHX or alcohol, whatever's in the kit. That'll depend on your hospital. Yeah, definitely go do your cleaning. Alright, let's kind of put this on hygiene. So we'll say skin checks. We can go ahead and add to home too, because we're kind of, a lot of the stuff is crossing over now. So we can go ahead and start doing our home one. So hygiene, we're going to do skin checks. We're going to be looking for any breakdown, anything that needs to be addressed or treated. What else are we going to do at home?
Vitals.
Hmm?
Vitals. Like checking their fever for infection.
Oh, vitals. Let's put that back over here. Temp checks. What temperature is significant in this population? 99. Alright, if you have a white blood cell count of 0.2, you are not going to have a temperature of 102 like you normally would. Yes, you still can, but a temperature of 99 is significant in an immunocompromised person. So for us, a temp of 99 means nothing, right? We're like, it's fine, your body is fighting. But for someone who's immunocompromised, a temp of 99 is significant because they have a very poor functioning immune system. So this is letting us know it's trying.
So this is all about safety for somebody immunocompromised.
We're trying to protect them.
But they would do like plasma, like giving them plasma or blood platelets. That's not really for their immune system.
So that's a great point, which y'all brought up over there as well. When we give blood, it is red blood cells. Does that help your immune system? When we give platelets, does that help your immune system? It's gonna help you clot. When we give plasma, it's mainly giving you volume. So none of those help your immune system. It can help other things because a lot of times if we've got an immune system compromised, a lot of times we have bone marrow compromised, so we kind of need those other things, but it doesn't help your immune system. But we do have one class of meds that will stimulate your bone marrow to create new white blood cells. So you may know the medicine. That one stimulates red blood cells. But it's very similar. We give it the same way, it just has a different name. So, is that the brand name or is that the generic name? Let me look really quick. Neupogen. Neupogen. Is that the brand name? It is a brand name. Filagrastim. Okay, let me write the brand name. The generic name. I'm gonna mark out Neupogen. This is the generic.
On the NCLEX, do they give both with one in parentheses or just?
Just the generic, because they don't sell brands in Canada, and Canada and United States take the same test. So blame Canada. That's why we can't have brands. We take the same test, Canada and United States. All right, so I like the brand name though, because Neupogen, what does that sound like? Neutrophils. So filagrastim, that is our medication that will stimulate white blood cell production. We give it just like epoetin alpha, so it's a sub-Q shot 3 times a week. It takes about 2 to 4 weeks to start working because it's got to stimulate the bone marrow. So this is a great medication for a lot of our cancer patients to try and increase their immune system.
You say 2 to 3 days or weeks to start working?
It takes about 2 to 4 weeks. Same thing, everything you learned about epoetin alpha, all the same. It's just instead of stimulating red blood cells, they're stimulating white blood cells. All right, what else can we do for these folks? What else can we do at home for these folks?
Emotional support.
All right, so we want to support mental health because that always helps. We said that helps our immune system work better.
No gardening.
All right, so no. So we really want somebody else to handle landscaping, cutting grass, planting flowers, all of that good stuff because we don't want them in the dirt. What else?
Family members can't get active vaccines.
Okay. No live ones. That includes, so all this stuff about visitors and things like that, it's also going to apply over here. So we don't want folks with live vaccines coming around them. We also don't want to give them live vaccines. What else? No what? All right, so others tend to pet kid needs. So sure, get out of jail free for changing dirty diapers, litter boxes, all that kind of stuff. If there is someone else in the house to actually be able to do this. So that is not feasible for every person. I wouldn't recommend getting rid of your pet just because you can't get rid of the pet needs, because that supports your mental health. So, so it's just, if there's someone else that can tend to those things, we want someone else to attend to those things. If not, it's just making sure we wash our hands really good, and that we clean everything up really good when we're finished. So we just gotta take extra precaution if you're the one in charge of it. What else?
What about staying away from large crowds?
Okay, avoid crowds. I just went to Disney. The people, oh my God, the people. I will never be in Magic Kingdom at night ever again. That will not happen. There's way too many people. Traveling, so we talked about traveling. We're gonna say travel concerns on here. It's pretty challenging to get on an airplane and avoid people. So it's just being more conscientious about if this is a trip I can actually do versus one that I can't. If we're really compromised, we may not need to get on a plane. We would not want to travel to third world countries that do not have adequate running water and things like that. So like some of these mission trips may not be a great plan for someone who's immunocompromised, as opposed to going to somewhere that's very clean, that has running water. You know, those are, you know, fine. Go on to London. But may not want to get on a plane for that. Wouldn't want to travel during peak flu season. If there's any type of outbreak going on in the country, we would not want to travel to those countries. So just have some travel concerns. All right, what else?
Keep them active so they're not sedentary and develop like
Active as possible. What else? I heard people talking about sharing things.
not share food.
Yeah. No sharing. We're going to say utensils, cups, which would be very hard for my daughter because I don't know why she can make her own water bottle, yet she must drink from mine if it is in sight of her. She literally came up and said, "Mommy, my tummy hurts." I gave her Pepto-Bismol, and then she grabbed my water bottle and took a big drink. Thank you very much. Well, now get me a new one. So, no sharing utensils, cups, foods, anything like that. We need to have our own. What else?
Neurochecks, do they need neurochecks? Neurochecks. Check the babies for the neuro.
Not quite so much.
Intake and
Would you do like,
What was yours?
I was just thinking of like going to all your doctor's appointments.
Yeah, staying up to date on all of your appointments, because a lot of times they have to have routine lab work checked, especially if they're on a lot of medications. So up to date appointments. There's some of these medications that if your white blood cell count drops too low, you have to stop them and you can't take them. So because they're depleting your immune system too bad. So definitely stay up to date on your appointments and your lab work that gets drawn.
Medication compliance.
Yep. We'll put that
I
on.
don't know if this would be a good one or not, but what about like electrical toothbrush? Because like you don't want to put like brush too hard and like irritation.
All right, so when we go to hygiene and skin checks, we want to be careful with razors, with toothbrushes, with you know, like exfoliation, anything that might cause a break in the skin. We want to be really careful with those type of things. We also want to make sure our skin is nice and hydrated, lotions, things like that, so it doesn't tear, break easily. What about your house, cleanliness wise?
I was gonna say, like, even if you have lids or not, to like disinfect everything.
I'm just gonna say clean house, disinfectant, keeping a kitchen clean, changing out your air filters, vacuuming up the rugs and the carpets, you know, making sure everything is just clean in the house in general.
If you can, get rid of rugs, stuff with the
Yeah.
air.
Anything that's going to, this again with pets, I'm not gonna make you get rid of your pets, but, you know, keeping pet areas clean, getting rid of things that are just gonna trap, all kind of dander and dust and stuff like that. Alright, I'm gonna add one over here to hospital. I'm going to add turn, cough, deep breathe. Because we've got to do our pneumonia prevention. Pneumonia prevention. We want our patients up and going to the bathroom as much as possible to prevent UTIs. So we've got to do all of those preventions and things like that. We want our dressings changed regularly. How often do you change a gauze dressing? Minimum every 24 hours, preferably every shift. Gauze loves bacteria. So you got to change them out. Change them out, change them out, change them out.
Unless they're on air or not in and out.
Yeah, that's a great one to go with the neutropenic stuff, is to limit how many interactions that we have with our patients. So kind of limit visitors, limit how many times we have to go in that room. We also didn't say with our neutropenic precautions, they should have their own gloves, their own stethoscope, those types of things. So we're going to say dedicated equipment. They may have their own Dynamat that stays in their room so that we're not bringing a lot of equipment into their room that is going into other people's rooms. Do y'all clean your stethoscope off after you use it with a patient? Thank you very much. A lot of people do not. You should clean your stethoscope in between patients. They did a research study, and your stethoscope's the dirtiest thing that you carry around with you because it touches so many people. So make sure you clean that stethoscope. All right, anything else we want to add? Or do we have a pretty good care plan going here? It looks good. Got all my stuff on it. And y'all added some things. Okay, so art people, y'all get to go first. So while they're making their way up here, I want you. Is this at the very end? Okay, so when you are up here doing your presenting, tell us things that you learned, maybe that you didn't know. So some of these may be longer presentations because you didn't know anything about this kind of class of drug. Some of y'all may have really short presentations because we already know a lot about this drug. But please don't read the whole poster to us because that gets really, really boring and people don't pay attention. So kind of hit us with the high points. Y'all ask questions at the end of presentations and let's just see how well Anna answers. Just kidding, I know her name. All right, Art there. Go ahead.
So the first part, we got a little too specific, so I'm just gonna skip that. It's the total therapy combined of 2 to 3 medications based off like what your type of HIV is sensitive to. And your goal is that you can't transmit HIV to other people, but you still have HIV, obviously. Immediately after you get it diagnosed, you need to start the therapy even that same day. And if you're pregnant and you find out that you have HIV, you need to start the medication as well because it can cross the placenta, it can be in breast milk, and it can be through delivery as well. Your side effects are great. It's nausea, vomiting, diarrhea, dry mouth, rash, pain, difficulty sleeping, headache, dizzy, fatigue. I don't know if that comes from the medication or the actual disease process. So just whichever one is fine. If you skip a dose or miss a dose, you have to talk to your healthcare provider because it can lead to resistance of the medication. And then you might have to change medications or you may not be eligible for the therapy anymore. That's what I just said. You can be infected initially with just, I guess, regular HIV, but you can also have drug-resistant HIV transmitted between people and start out resistant to drugs. And I did not know that part, so that's what we had to look up. But that's pretty much it.
Good job. We have questions for her. I have things to add, but do y'all have any questions? Did y'all know art therapy was what we treat HIV with? Because usually when I sign this out, people think I'm talking about like painting, like art therapy.
So is this when you watch commercials and they say it's like non-detectable, that's what that would be?
Alright, so that was the same kind of questions they had back in the back. So when we talk next week, a lot more about HIV, how it works, all those different things. Art therapy is what we give patients who are diagnosed with HIV or AIDS. We have those treatments, you guys all see the commercials for PrEP, right? Or commercials, the ads, if you're not, rich enough to not have ad TV. But there's ads everywhere on PrEP, which is trying to prevent, so it's prophylactic. And then we have PEP, which is post-exposure. It's all variations of this art therapy, trying to either get it under control, prevent it, or prevent you from transmitting it. So yeah, everybody with HIV has to take this medication. If you want to live. If you don't want to live, don't take it and you can die from pneumonia. Because that's what happens. They usually die from pneumonia.
How long would it take?
You can take this your whole life. If
The process from like refusing therapy.
you can die within 6 months. 6 months to a year is what the average lifespan is for untreated AIDS. So we're going to learn about the stages of AIDS. So I'm talking like when you're in that final stage, 6 months to a year.
We're doing that next week. We're going
Next
to that
week.
next week.
Wasn't there like a skid? Do you know what I'm talking about? There was some, I wanna say it had something to do like with HIV or AIDS. Like before they really knew that's what it was. It was like a.
What was the word you said before?
Skid? Like SKID, it was kinda like a, what do they call them? Like where there's, that's just the letters. That. Is that not what I'm not about to Google skid?
Alright, your job is to find out more about your question and ask it next week. Or after class.
Can they go from like the PEP to the art? Like, can PEP not work?
Yeah, so we'll talk about PrEP, art, and PEP, kind of the differences with those next week. The main thing with this one that she really pointed out was if you skip a dose or if you miss a dose, you need to talk to your healthcare provider because this virus is so smart. It is so incredibly smart so that if you skip your dose, the medicine you were on is not going to work anymore. So you have to take this as prescribed.
So they'll most likely just switch up and then if you skip
Yeah,
this.
you're probably gonna have to change dose or change medication. So drug resistance on this is extremely high. So that's why she said you can even swap around. If you have one strain of HIV that's resistant to this drug, you have one strain of HIV that's resistant to this drug, and it can be passed back and forth between people. So this virus is very, very smart, but this therapy is also very, very good. So Magic Johnson was diagnosed in 1986. He is still living his life because he is on art therapy and he takes it every single day. And you have a normal life expectancy with this therapy. So there is no shortened life expectancy with AIDS anymore if you take this therapy appropriately.
It's kind of crazy though, because with like COVID and stuff, they came out with like antiviral medicines that would like help you get rid of it. But this seems to be obviously you can't get rid of it. There is no cure. That's crazy.
They're starting to get some genetic therapies though that we might be getting a cure of soon. I got two back there.
So if you like skip a dose and you're not educated on that and you like skip for like 3 times out of a week and not thinking about it, and like, will you know that you, like, can your body tell that you
You'll
have drug
flare up.
resistance? Okay.
Yeah, you'll
But like
flare
in
up.
that time frame, you're giving it to people. You're
Yeah.
like, okay.
Yeah, so think of this as what's keeping it under control. This art therapy keeps it under control. As long as it's under control, you're not going to pass it around to people. But if you skip doses, don't take it how you're supposed to, it's going to mutate, and then you may as well just stop taking it. So it used to be on the website, it would say, if you don't take it 90% of the time correct, don't even bother. It's either take it 90% of the time correctly, or just forget it. cause it's not gonna do anything. So it's
So
not big, then I saw it.
SCID is severe combined bacterial deficiency. That's what it is, it says,
Okay.
a genetic mutation for T cells and B cells.
Okay, so
Is
it
that
sounds like it's
the
just
same
kinda
thing?
describing the disease. That's what it sounds like. We'll discuss more. Ava, I know.
So if those upsets are all from the medication that they're taking, what does like a flare-up look like? What do you?
You're just sick. Like, you get pneumonia really easy, you get all types of infections really easy. Cause remember what I said, nobody dies from AIDS, you die from an infection. So, we fight off infections every single day. You're fighting off an infection right now. Your immune system is working. So, with HIV and AIDS, unless you're on this therapy to keep the HIV down and your immune system up, you're gonna get these infections that we fight off all the time, and you're gonna die from these little puny infections that literally nobody else dies from. So this is an amazing therapy. It used to be, Magic Johnson used to have this little thing where he would bring out a pill bottle that was this big, and he's like, this is how many pills I have to take to keep my HIV under control. Now you can do, so that was one thing. Did y'all talk about the different types of administration? Like, you can take pills, you can take, they've even now got a shot that'll last 2 months. So you can go in and get an injection. And that way you don't have to worry about taking the pill every day. So you can get an injection that'll last you 2 months and just go in every 2 months for your injection. That's like a life changer for people who just suck at taking a pill every day. So not everybody's good about that. Alright, any other questions about art therapy? We're gonna talk more about it next week because art therapy is just, that is the treatment for HIV. Like, that's it, that is the treatment. If you wanna live, you take it. If you would not like to, don't take it, and then good luck. So we'll talk more about it next week too.
For HIV and AIDS?
But you could get art therapy. Yeah, that's really about it. Alright, my chemo people. You're next. Rock, paper, scissors, or everybody come on.
Okay. High dose chemo obliterates bone marrow. It is a vesicant, given only in the central line. It's highly toxic, so as a nurse, you must wear special PPE to administer. And everything goes into a special waste box. Like we said, it suppresses the bone marrow, causes fatigue, GI upset, and other issues, severe mouth ulcers, esophagitis?
Yes.
Say it with confidence. Okay. Also, infertility issues. So, if you know you're going to have chemotherapy, you might preserve stuff ahead of time, whether you're female or male. Supportive care, isolation, neutropenic precautions, growth factors, transfusions, mouth care, like we talked about the ulcers, strict infection monitoring, nursing priorities would be daily labs, electrolytes, renal, liver function, ANC like we talked about earlier. We're gonna monitor for early infection, signs and symptoms, and look for a low-grade fever. We're gonna have bleeding precautions, no IM injections. They're gonna use soft toothbrushes, no aspirin or NSAIDs. And we're gonna educate the patients about self-care at home.
So I asked them to focus on like high dose chemotherapy. Obviously there's chemotherapies that are like a pill that you can take every day for maintenance, kind of like that low dose. We're gonna mainly focus on if you can take care of the worst case scenario, you can take care of all those other little bits. Why does chemotherapy cause bleeding issues? Why do they have low platelets? told them I liked that right there. So causes bleeding issues, causes fatigue, causes infection risk, all because suppresses that bone marrow. If you don't have bone marrow working, you don't get those stem cells to come out like we showed on that PowerPoint earlier, which means you have none of the good cells. EpiPen people, love how we're surprised. Like, ooh.
Epinephrine, it's a vasopressor used to treat type 1 allergic reactions. The IgE reactions that we usually lead to anaphylaxis. It can also be used for certain asthma cases as well. EpiPens will do two important things. They're gonna have bronchodilation, which will make it easier to breathe, and vasoconstriction, which will raise blood pressure and reduce airway swelling. The most important thing you need to know and your patient needs to know is how to give an EpiPen. So what you're gonna have to remember is blue to the sky, orange to the thigh. You're gonna give it in the side of your thigh. You are gonna do it all the way because it's intramuscular. You're going to hold it for 3 seconds, and then you're gonna take it out and massage the site for 10 seconds. That's right. And then if symptoms don't improve within 5 to 15 minutes, you can give another dose. Afterwards, you need to take the patient, or they need to go to the hospital right away. You need to make sure that they are given the correct dose as well, especially in the hospital, because it's going to raise your blood pressure and your heart rate. Oh, it can also cause hypoglycemia and hypokalemia. I didn't see that earlier. So in the hospital, you're just gonna have to watch your patient closely, teach them this for home use, and that's about it. I'm pretty sure. What was the most popular allergy?
Tree nuts.
Tree nuts.
So, what's the most common medication allergy? Yeah, John did second.
Sulfur.
There you go, sulfur, yep. Sulfur. What else do y'all know about EpiPens? Do what?
No, I'll go on epinephrine for cardiac arrest, not EpiPens.
Yeah, we're not there yet, we're not there yet. We'll get there, I promise, we'll get there. The EpiPens, what else do y'all know about? They are expensive, yes they are. What else do we know about them?
They don't work if you don't have one.
They don't work if you don't have them on you. So if you leave it at home, it's not gonna help you if you're here at work. Oh, she said she forgot to say it can go through jeans, so you don't have to remove their clothes. You can go straight through the clothes. Yep, it's on here.
I was reading it, I was like, yeah.
Yep, so you can go straight through the clothes. It just avoids seams of pants because that's pretty thick. But yes, you can go through the clothes. She said blue to the sky, orange to the thigh. Please don't mix that up because nobody wants somebody that injects their own thumb. You also should not inject, like if you're holding one, don't inject it like this just for that risk so that you don't inject your own thumb. Just hold it like this. It's an auto injector. You slam it down and hold it, it's gonna inject itself.
Blue
So
to the
you
sky.
just hold it like this. Do it.
Blue to the sky, orange to the
Orange to the side.
Do they ever expire?
They do expire, so that means we need to buy new ones. So we gotta keep up with their expiration date and buy new ones. If I have an expired pen and I start to have a reaction, am I gonna give that expired pen?
Yes.
Yes, I am, because an expired epi is better than no
And then
epi.
take them to the hospital.
Yes, so just know you can give expired epinephrine, it's just not gonna pack the same punch as a non-expired epinephrine. So we want them to replace it as soon as it is expired, because personally, if I'm gonna have an allergic anaphylactic reaction, I would like that full dose of epinephrine as opposed to maybe a half of a dose because it's a really old pen. But if the choice is half a dose and no dose, I'm gonna take the half dose. So it's better if we have one that's not expired. What else do we need to know about them? Is that most of it? I think y'all got most of it. Yeah, main thing, don't inject yourself. That would be really bad. Keep it on you at all times so that you can use it if needed. Go to the hospital. Why do they say go to the hospital?
It doesn't work.
Don't work. Or if you're really allergic to tree nuts and you ate a whole dish that you had no idea had tree nuts in it, there might not be enough epinephrine in those 2 pens to counteract, because epinephrine has a very short half-life. So it could wear off and your symptoms can come flaring back up again. So short half-life, so go to the hospital, go to the ER.
I think you kind of, no matter what, even if you feel better after storage.
Yeah, especially if you have to use 2. If you gotta use 2 doses, you need to go, because like she said, you can give that second dose after 5 to 15 minutes. So if you're having to give it in 5 minutes, you better be on the way to the ER, like immediately, so that we can give you higher doses. We can start the Benadryl, the steroids, the fluids, the oxygen, all the things. Because unfortunately, a lot of people die before they get to the hospital with an anaphylactic reaction. There was a girl in high school this year, it was maybe in the spring, there was a high school girl that didn't make it to the hospital, and she was local, one of the local high schools. Didn't make it to the hospital after eating baklava. She didn't know that had nuts in it. And she even asked, and the worker that served it to her, and she didn't know either. She ate it. High school kids are not known for being super smart. So I don't blame a high school kid. I mean, I hate it for her.
But the worker, if you don't know, go ask somebody.
I'm sad about the worker did not at least try to find out, or they were misinformed. So it sucks all around. So go to the hospital, that's the big thing. Alrighty, so that we covered medicines for allergies, cancer, and HIV. Now we're gonna get into, this is our autoimmune diseases. There's a lot of meds for autoimmune diseases. So, least invasive, NSAID people. Y'all should be quick, because we know a lot about NSAIDs. I'm assuming, maybe y'all learned a lot of new things.
So NSAIDs like aspirin and ibuprofen, anti-inflammatory, analgesic, and antipyretic effects. It decreases prostaglandin, which leads to inflammation. The adverse effects of daily use, the daily use of NSAIDs is GI bleeding, ulcers, like heartburn, things like that. Bone strength, I did look it up, bone strength, the prostaglandin, it inhibits that, so it leads to decreased bone strength. Electrolyte imbalances, patient education is to stop before surgeries because it increases bleeding. No razors, or look out for razors. You can use electric razors. Toothbrushes, no alcohol with them. Don't combine with other NSAIDs, and elderly means increased sensitivity to the effects.
What other organ do we worry about?
Liver and kidney.
Kidneys. So, not really liver. Tylenol is your liver, NSAIDs are your kidneys. So yeah, they really don't affect the other that much. Yeah. That's what, steroid people, you want to go ahead and make your way up here. That's what makes me laugh, this whole social media frenzy about Tylenol. Like one half's like, Tylenol's safe. I'm like, Tylenol causes liver failure. Like, y'all chill.
The liver regenerates though, right?
No.
No, it doesn't,
I
okay.
mean, it can if you stop damaging it so much, but the liver is fantastic at compensating. So then you get like 10% of your liver working, because the rest of it's shot to all get out. All right, my steroid people, they made you a book.
Yes, we made a drug book.
It's really pretty.
So we are doing corticosteroids.
Y'all are so extra, I love it.
Okay, so corticosteroids. So we all know what steroids do. It's immunosuppressants. We are talking today in context with lupus and rheumatoid arthritis. Please pardon my pronunciations. Okay, so there are 3 drugs that comes under it, which is prednisone, which can be given PO. Then we have hydrocortisone, which can be topical or can be given PO. And the third one is methylprednisolone, which is IV. So these are the 3 categories that the ways it could be given. The fancy MOA, in very simple term, it suppresses the inflammation and immunity. That's what I would put it as an MOA for the corticosteroids. What kind of effects does it give when you have lupus? So basically, it lowers down the immune system, joints, skins, kidneys, inflammation of blood vessels, organs, relieve the joint pain, rashes, fatigue, and pleuritis, which is infection in your pleural cavity, which is your lungs, base of the lung. Rheumatoid arthritis lowers your, again, same thing, stiffness. That's the biggest one. And slows the synovial membrane infection, which is related to our bones. We're talking about osteoporosis, kind of related, like bones related. And it provides the rapid symptom reliefs while waiting for DMARDs. The corticosteroids are always given, it's called bridge therapy, right? So it's with the bridge therapy it's always given with another medication, mostly it's DMARDs. That's what our information was, but yeah, that's what it's being given with. We got a mnemonic for this one. So we all know Cushing's is one of the other autoimmune disorder, which is because of higher cortisol levels, and that's why we did mnemonic on Cushionoids. Is that what we said? Okay. Okay.
Like steroids.
Yes, like steroids. Yeah. So Cushionoids. So we just did that. The biggest one, before we get into this one, but what I remember is the biggest one with corticosteroids is the moon phase. That's a very big one. The buffalo hump, which is like a big nodule on the back of your neck because of that cortisol accumulation. And the other one, the big one, is hyperglycemia. You have to really, really watch on the blood sugar of the patients because that could be dangerous for them. The other ones are the patient can get all kind of GI, peptic ulcers, GI upsets, all those kinds of symptoms. Bleeding, skin, the skin can be easily have bruising, so we have to be very, very mindful and watchful for that. Hypertension, hirsutism, which is they will have hairs all around most of the face. That's what they call it. It's called hirsutism. Hypertension comes with that. Delayed healing, so we have to really monitor. Necrosis, again, glucose elevation, hyperglycemia. Osteoporosis is a big one. Obesity, truncal, which is kind of, we're talking about fluid retention. Insomnia, a lot of psychosocial disturbance that they might have, mood changes, irritability, all kind of depression. And then there is the one that we found out was delayed growth in the kids. So if kids are having this, then you would see a delayed growth in them.
I definitely see why you have depression. Like, you just paint a very dire picture. That's why I have beers. What else do y'all know about steroids? Like, because I asked them to focus on daily use, but she also said this is a bridge therapy. So it's a bridge therapy to get us to the meds that we're going to cover here in just a second. So if we're going to just use this as a bridge, so we're going to stop using the steroids once we get therapeutic on these, what do we have to do when we're stopping the steroids? Wean and taper off. Why? So why do we have to wean? Everybody always knows that one. You're like, wean steroids, taper off steroids. Why is that important? So this is always where it gets stuck. It's very, very dangerous. It's not like you're gonna get nauseated.
What shock?
You can go into circulatory shock. Yes. So our body lives on steroids. You must have steroids to live. If you don't have steroids, you will go into circulatory shock and die. You must have steroids. So if we are taking steroids, first of all, who makes steroids in your body? What organ? Your adrenal glands. So if you're taking steroids, what are your adrenal glands doing? They sit back, having a drink. Like, you got this, you don't need me anymore. So if you stop taking it, your adrenals are on vacation. They're not producing anymore. So you then have no steroids. So you guys are going to learn in 211, you're going to learn Addison's disease, which is where your adrenals fail to produce steroids. Because we have Cushing's, too much steroids, Addison's, not enough steroids. So I've had 2 Addison's patients before, and when I tell you, when it came time to give her Q6, methylprednisolone, or no, she was on hydrazone, and then she was also on another glucocorticoid. So she was on a corticosteroid and a glucocorticoid. When it came time to give those, if I was 30 minutes late, her blood pressure would drop from like 120 down to like 90 systolic. Like, if I was an hour late on her steroids, her blood pressure would drop significantly. So, and that's because she didn't produce anything. She had Addison's disease, so she didn't make any steroids. So if I didn't give her steroids, she was starting to go into shock. So that's why it's extremely important, especially with these guys, because it is a bridge therapy. They're going to be on very high doses of these steroids. So as we bridge them to the DIMARD therapies, we want to taper those off so that we don't cause any massive problems.
Is that why when you get a steroid pack, it's like tapers down?
Yeah, because you guys probably wouldn't go into circulatory shock because you're not getting a huge
Yeah.
dose, but it may make you feel really tired, fatigued, and exhausted because of not having as much steroid as you're used to. But when you're talking about giving these IV massive doses of steroids, like you gotta slowly come off of that. Or if you're on long term, like if you take a Medrol dose pack, what is that, 7 days? 10 days at max? But what if you took it for like a month? So a month, your adrenal gland. How good? Y'all have fun. So bridge therapy to the DIMARDs. All right, so all 3 of these are all in the same category of DIMARDs. So I'm gonna let my methotrexate people come up because this is usually the first line DIMARD. So you guys have the hardest job because you got to kind of tell us about what a DIMARD is. My hydroxychloroquine and my monoclonal antibodies, you got a little bit easier of a job because y'all don't have to repeat everything he says. So if he fails to tell us something that y'all want to bring up, go ahead.
Well, like she said, it is a pretty complicated thing. We kind of tried to dumb it down a little bit, but let's start from the beginning. Methotrexate. It's a conventional DMARD. It is usually the first line treatment for rheumatoid arthritis, some psoriasis. It very basically, when you look up like the mechanism of action, you're going to see a lot of big fancy words that you may not 100% know what you're talking about. We tried to simplify it. It's essentially a folate antagonist that leads to inhibited DNA synthesis. Now, what am I talking about there? It really likes like rapidly regenerating tissue, skin, bone marrow, liver, not kidneys, but essentially those. It can also be used to treat cancers and stuff. But our little dumb thing was suppresses the immune system, lowers inflammation. Some side effects for it, bone marrow suppression, of course, like I just said, so anemia, leukopenia, thrombocytopenia. It's very toxic to the liver. It's very toxic to the nephrons. You cannot be pregnant while taking this. It will, it's teratogenic. It will, I I guess causes spontaneous abortion, I think is what you would call it. You have GI problems, it's usually the general ones, but it can also cause like stomitis, I believe is one of them, but like nausea, vomiting, all that fun stuff. In very rare cases, you can have pulmonary fibrosis caused by it, but you're also going to have photosensitivity and possibly even alopecia. So that might be a good patient teaching for somebody that after you start taking this, you might have some kind of hair loss. So, fun little contraindications. Pregnancy, of course, lactation, it can be transferred through that milk as well. Immunodeficiency, if you are already immunodeficient, it might tank you even further. And if you already have any severe renal impairment or severe liver impairment like cirrhosis and stuff. So what do we want to consider as the nurse? So we're going to be monitoring their CBCs, liver function tests, and renal tests, keeping an eye on those, making sure we're not just destroying their function. This one was odd to me, so I had to look it up myself. Administer folic acid supplements. Well, up here we're saying we're inhibiting folic acid, like the transformation of it. I'm forgetting the word right now. But apparently, the reason we give folic acid supplements is because it can reduce some of these side effects while not lowering the efficacy of the drug. Once again, do not get pregnant, teratogenic. Apply sunscreen because of your photosensitivity. Educate the patient to report like fever, bleeding, bruising, coughing, shortness of breath, jaundice. So essentially signs of infection, signs of decreased liver function. And of course, you have an increased risk for infection. Drug interactions, NSAIDs, bleeding, penicillin, sulfonamides. Avoid live vaccines again because you are much more immunocompromised, and avoid alcohol, bad for your liver. Antidote, if things go too bad, we have leucovorin. I think it's the brand name, but folinic acid is the generic. It bypasses this blocked enzyme and quote unquote rescues the endangered cells. So I think that's about it.
Very nice. I had to look up leucovorin. Y'all teaching me new things. Prevention of side effects from methotrexate. Interesting. It also says it can be treated as autism. Okay, I want to learn more things. What? I did autism. That's what it said. I just looked it up. I'm gonna learn more about it later. So very good. Methotrexate is usually our first line medication. So patient gets arthritis, lupus, we do steroids, NSAIDs, bridge them up to where they're therapeutic on methotrexate, and they do very well. So it's pretty common medication. So that whole care plan that we just did a little while ago before lunch, he said all that infection risk, that's what we're gonna do for them, because y'all already kind of copied some of the stuff that we said already. So that's exactly right. So that whole care plan we're gonna do for somebody that's on methotrexate because they are having that decreased immune system, so we have to protect them. Most of the time this is gonna be lifelong because autoimmune diseases, unfortunately, typically stay lifelong. We don't have cures for those. So they're gonna be on these therapies lifelong. So we gotta take care of that infection risk while they're on it. All right, hydroxychloroquine.
So
Question
what
or
you
stretch?
said, we will have them on NSAIDs and corticosteroids until their DMARD levels are therapeutic?
Typically, because we use those as a bridge to get them up on those treatments. And then if they have an exacerbation and they're really struggling, we may go back to NSAIDs and corticosteroids for a little while to kind of get them over a hump if they're starting to have a lot of pain and inflammation. So, but typically we can usually keep them with this, with just that, and not have to have those two. So, but over somebody's lifetime, they're gonna go back and forth between having to take all these other meds as they flare up. All right, my hydroxychloroquine, folks. This one got a lot of social media airtime several years ago.
Okay.
Have at it.
Hydroxychloroquine falls under the DMARDs, so it works by inhibiting lysosomal enzymes to produce the anti-inflammatory effects. So it got some few side effects like a blood vision, like that's the main one I think, and retinopathy. It has effects like thrombocytopenia, liver failure, ventricular arrhythmias, and QT prolongation. So for the nursing considerations, so you want to make sure you're assessing for hypersensitivity to the drug, actually to the general class of these drugs. I mean, quinoline, something like that. You want to assess for any existing retinopathy, hepatic and renal disease, any vision change, skin rash, and as an assessment of vital signs, EKG for any arrhythmias, and then provide education. Make sure the patient gets some ophthalmic examination every 6 to 12 months. And then you want to teach the patient take the medication with food, especially milk. And it can also be taken with NSAIDs according to the book, except for digoxin, because it can increase the level of digoxin in the system. So you wanna consider that one. And then limit sun exposure. And then something I forgot, it has like a long onset from 2 to 4 months actually. All right, that's all we got.
So methotrexate, hydroxychloroquine work different, do the same things. Hydroxychloroquine causes a lot more cardiac and a lot more vision issues. So if they don't do well on that, we would swap them to a methotrexate and see if they do better on that. If they don't tolerate methotrexate, we may swap them to hydroxychloroquine to see if they do well on that. So it's really just which one works better for the patient to keep their symptoms under control. But this one does tend to have a little bit more side effects and problems than methotrexate does. This is why we tend to like this one as the first line a little bit better. But if they don't tolerate it, we can swap them to this. If they don't tolerate either one of these, we can swap them to our last group, our monoclonal antibodies, if y'all want to head up here. We typically don't start with monoclonal antibodies because these suckers are expensive as all get out, and insurance don't like paying for them, and insurance companies cause all kind of problems saying, well, why don't you just do one of these two? Well, it's because those are much better. They don't have as many side effects, but they're just very expensive.
So our group had the monoclonal antibody DMARDs. And I didn't know what this was going in, but a DMARD stands for disease-modifying anti-rheumatic drug. So obviously helps with autoimmune things like rheumatic disease. And anyways, what exactly is monoclonal antibody DMARDs? It is a biological DMARD targeted directly at specific immune system molecules like the TNF-alpha and the B cells. Directly to decrease inflammation in autoimmune diseases such as rheumatoid arthritis and also the psoriatic arthritis as mentioned earlier. And I'm sure we're going to have these passed around in the group me and all that. So the pronunciations are really going to get to me. But the generic pronunciations are adalimumab and influximab. Anyways, the suffix for these medications is MAB. So any kind of MAB mob medication is a monoclonal antibody DMARD. More widely known as Humira, to make everybody's life easier except for on the exam. So specifically, our information is targeted at Humira, but as we were told by Dr. Hicks, that it is universal for all the mob medications. So on our exemplars and stuff, this is what it's talking about.
That's what
Anyways,
all commercials are now.
yes.
Skyrizi,
Mhm.
Humira, like they're all.
I like their names.
Yeah.
Yeah. They got cute little names.
Cute.
They got generic garbage names.
Yeah, good luck with that. Anyways, just know the suffix. Their therapeutic class is TNF blockers, and their pharm class is immunomodulators. To administer this medication is sub-Q every other week And it could very well be weekly, depending on your provider, if the efficacy and your levels and your symptoms are not improving as they would like. So it could be weekly, it could be bi-weekly. You want to administer in the lower abdomen or the thigh. You don't obviously want to give it in the damaged areas. You don't want to get it in a stretch mark, a bruised spot, any kind of scar really, so don't give it in those damaged areas. It is a cooled medication, so it's kept in the fridge. They advise you to leave it at room temperature for about 15 to 30 minutes, just because if you give it directly, it's quite painful. So yeah, just let it kind of adjust to room temperature a little bit, but not too long to where it loses its efficacy. You want to protect the medication from light as well. And another warning they gave was that the needle or the needle cap may contain latex, so you need to talk to your patient about if they have latex allergies. Some side effects can include headache, diarrhea, upset stomach, tired, weakness, fatigue, flushing, some signs of common cold, pain, redness, and swelling at the injection site. Some adverse reactions include GI hemorrhage, liver necrosis, malignancy. More than common type of malignancy is the lymphoma that gets reported. It can also lead to heart failure and MIs, bronchospasms, hypertension, encephalopathy, and an exacerbation if you have MS, multiple sclerosis. Some drug-to-drug interactions is if it's taken with other of these DMARDs up here, it can cause serious infections or neutropenia. And also, like they've said, avoid the use with live vaccines. The black box warning is very serious. You are more at risk of serious fatal infections in combination with immunosuppressant concomitants. Some examples are methotrexate and corticosteroids. And that is all I have.
Very good. We had a kid, and I was telling them, we had a kid in clinical a month ago that was on Skyrizi, which is monoclonal antibody, and he almost died from a liver abscess. Just got a liver abscess. Didn't have trauma, didn't have like alcoholic liver, like nothing. He had no liver issues, anything, but just developed an abscess. So just developed a liver infection. And his literal only thing in his entire medical history, because he's only 25 years old, was he was taking Skyrizi. That was it. So that's why he got that horrible infection. So can be very dangerous, but you know, that's the one that has the least side effects as opposed to the other two. That's why insurance don't like paying for them, so they're very expensive. So how do we feel about medications? Feel pretty good? All right, so next week we're going to be going into each of the disease processes. So I'll probably start us out with the Kahoot about cancer. So we'll do that one kind of first. Get into the HIV case study, go into allergies. I've got an activity for allergies, lupus, rheumatoid arthritis. So we'll kind of go over all of those next week.